Okay, thank you so much. First, I'd like to thank the ECLA committee for having me here, and I'd like to start my presentation. I wish you good luck against the coronavirus, and I hope the world will get rid of this nightmare as soon as possible. This is my general financial disclosure. And the neurotrophic keratopathy is one of the challenging ocular surface disorders in our practice, and most of the cases are refractory to conventional treatment, and the treatment takes too long, and sometimes it may cause visual impairment. So once the diagnosis of neurotrophic keratopathy is established, the treatment needs to be initiated immediately to prevent the progression, and the aim of the management should be set to promote corneal healing and to avoid complications. And at this point, we need new therapeutic agents and the new therapeutic modalities. Before talking about the potential new treatment agents, we should know the basic mechanism of corneal wound healing. The epithelial, stromal, and endothelial wounds heal by different mechanisms. And the corneal healing is a complex and regulated sequence of cellular reactions. And it's a coordinated cascade of growth factor action, activation of various cross-talking pathways, cell proliferation, migration, and extracellular matrix remodeling. And the corneal nerves and immune system cells play significant roles in this process. And corneal epithelium and stroma interact with each other during healing. For instance, epithelial wounds cause keratinocyte apoptosis through the release of interleukin-1 alpha, and stromal wounds invariably involve the epithelium. That's why interleukin-1 alpha is one of the important molecules that investigated for corneal wound healing. And endothelial cells are relatively less affected by the epithelial and the stromal wounds. Let's talk about which targets may be potential as new therapeutic agents on the horizon. Limbal stem cells are essential in the maintenance and repair of the cornea, and depletion or the absence of limbal stem cells results in impairment of the corneal wound healing. And there are two approaches to remedy this deficiency. The one is the cell transplantation using the desired cell population obtained in tissue culture. The second one is cell transplantation using cells such as corneal epithelial, where stem cells are dissociated and cultivated on a supporting matrix like an amniotic membrane, fibrin gel, or polymers. As an alternative solution, a few groups have recently focused on a new approach by mimicking the limbal stem cell microenvironment in which the limbal stem cells live. We can call artificial limbus. The application of this principle in the engineering of limbus tissue can be translated into mimicking the three-dimensional morphological structure of tissues in order to provide a specific niche to support stem cells. In addition to limbal stem cells, growth factors and cytokines are important regulators that stimulate growth, proliferation, migration, differentiation, adhesion, extracellular matrix deposition, and proteinase regulation. And there are numerous targeted agents that could potentially accelerate corneal wound healing. Let's summarize these agents, including the epidermal growth factor, insulin-like growth factor, transforming growth factor beta, platelet-derived growth factors, thymosin beta-4, nerve growth factor. And these are all new targets for the treatments. Another important step of corneal wound healing is basement membrane proteolytic remodeling. And proteinase activity may affect extracellular matrix remodeling. With new treatment modalities, including gene therapy, microRNA, inhibitor therapy, it's possible to fine-tune proteinase expression and activity for optimal healing. These treatment modalities on the horizon seem to be very, very important for obtaining a near original cornea after the treatments. While no cell transformation has been documented during the healing process of the epithelium, in contrast, keratocytes get transformed into activated fibroblasts and then to motile wounds contracting and alpha SMA expressing myofibroblasts as seen in the picture. And the main signaling complex driving these processes is TGF-beta system. And this system is tightly regulated with pro-fibrotic TGF-beta-1 and beta-2, and on the other side, anti-fibrotic TGF-beta-3. And the result of their interplay is not always predictable, and excessive healing may occur, leaving stromal haze and or extracellular matrix recurring. To reduce this fibrosis, the gene therapy with decorin and BMP7, as well as the use of some approved drugs, have already shown promising results. As I mentioned, corneal nerves are one of the indispensable parts for corneal wound healing. And in addition to their important sensory functions, corneal nerves induce reflex tear production, blinking, and release of trophic factors, helping to maintain the structural and functional integrity of the cornea. Several molecules have been studied that may have a positive effect on corneal nerve regeneration. Among these molecules, the NGF, vascular endothelial growth factors, semaphorins, neurotropins 3 and 4, growth-associated protein 43, neuropeptides such as substance P and insulin-like growth factor 1, used to treat delayed wound healing due to corneal nerve damage. And hopefully, as has previously mentioned, the oxalate and ophthalmic solution containing the recombinant human nerve growth factor is the first drug to be approved for the treatment of neurotrophic keratopathy. Approval of NGF protein is an extremely important improvement for the management of neurotrophic keratopathy. On the other hand, some studies documented additional effectiveness of some combinations, such as a combination of pigment epithelial growth factor or NGF plus docosahexaenoic acid, which is an omega-3 fatty acid, may promote corneal nerve regeneration. I would like to share two relevant studies in animal models. The first one is related to the use of pigment epithelial growth factor and plus nerve growth factor, NGF. In this study, the authors documented that the peptide for MER-PEDF in combination with DHA, omega-3, is an effective and selective treatment for corneal nerve injury that can modulate the inflammatory response, promote the recovery of corneal sensation, and increase tear production. In the second study, the authors suggested that the combination of the NGF plus DHA may yield a faster nerve recovery after PRK in animal model and may have therapeutic usefulness in the treatment of post-PRK dry eye and other neurotrophic keratopathies. Before finishing my presentation, I would like to share what I can currently do in my practice when I see a challenging case. Paying attention to all small details in these cases determine the final clinical success. From this point of view, lubrication is an important part of the management, and I believe our preferences should be a little bit different. In these challenging cases, I always prefer preservative-free agents having different features. I'd like to give some examples. The one of them is a combination of trehalose plus hyaluronic acid. As we know, the hyaluronic acid is a well-known lubricant agent. And in this combination, trehalose provides cell protection because of its feature, including the osmoregulation, protein protection, stabilization of membrane lipids, induction of autophagy. On the other hand, another preference is the combination of the coenzyme Q10 plus cross-linked hyaluronic acid. In this combination, while cross-linked hyaluronic acid stay longer on the ocular surface and have more stability against the heat, free radicals, and the pH changes, the coenzyme Q10 may accelerate wound healing through its bioenergetic features. This is my paper published 3 years ago. In this paper, I shared my challenge cases, such as neurotrophic keratopathy, and all patients were treated successfully with coenzyme Q10 eye drops, in addition to conventional therapy. In some other cases, I prefer using either autologous serum or PRP, as the autologous serum involves numerous growth factors essential for wound healing. However, it may have some disadvantages, including the draw blood repeatedly, risk of infection, the cost, and the medical legal issues. On the other hand, the PRP also provides more growth factors, and they provide essential growth factors which are involved in stem cell migration, differentiation, and proliferation. In literature, when we look at the literature, there are some papers showing that the PRP eye drops could be a safe and effective therapeutic option for patients with stage 2 and 3 of the neurotrophic keratopathy. Another alternative is topical omega-3 plus vitamin E eye drops, mostly combined this formulation with either autologous serum or PRP to accelerate corneal wound healing. And topical RGTA eye drops, which is a matrix agent mimicking heparan sulfate, is another option for challenging cases. In literature, there are some published data documented that it may accelerate corneal healing, particularly in neurotrophic keratopathy. And my last preference is definitely sectoral contact lenses. This case report was my first experience while working with Professor Fulfelder in Baylor. And to be honest, I was so surprised when I saw the effectiveness of the PROS lens in these cases. Unfortunately, we don't have the PROS lens in Turkey, but we can use similar semi-custom made sectoral lenses coming from Europe. And the take-home message, treatment of neurotrophic keratopathy is challenging, and time is critical to avoid the complications. New agents to accelerate and optimize the corneal wound healing are needed, and hopefully topical human recombinant neurogrowth factor eye drops approved and have already shown promise. However, as it was mentioned before, the cost seems to be problematic, especially for Turkey. And new alternatives will be possible using the new treatment modalities, especially including new gene therapy, microRNA, and the nanocarriers. Thank you for your attention.